Okay, so this is your psychological disorder chapters. There's audio that's associated with some of your slides. I've done the SAS, which is Screening Assessment Support Services, and crisis work in the hospitals for the last 5 years or so. So I see patients when they're in crisis, when they've attempted suicide, when they're contemplating suicide. Sometimes they're having behavior issues. So there can be a variety of things that put a person in crisis and require an assessment. So it's my job to determine whether or not they're safe to go home or whether or not they need inpatient hospitalization or what type of treatment that they may need. So this chapter will walk you through some of the different disorders and elaborate on what you're reading in your textbook. So abnormal behavior looks different across different cultures. Cultural norms provide guidance about how people should behave and what behavior is healthy or unhealthy. The definition of normal can change as society changes. Cultural norms can be limiting, oppressive, and prejudicial. Individuals who fight to change the established social order sometimes face the possibility of being labeled deviant and even mentally ill. Many of the diagnostic categories we trace in this chapter primarily reflect Western and often US notions of normality, and applying these to other cultures can be misleading and even appropriate at times. There are 3 approaches that we take when examining for psychological disorders. The biological approach attributes psychological disorders to organic or internal causes. This perspective primarily focuses on the brain, genetic factors, and neurotransmitter functioning as the sources of abnormality. The biological approach is evident in the medical model, which describes psychological disorders as medical diseases with a biological origin. The psychological approach emphasizes the contribution of experiences, thoughts, emotions, and personality characteristics to explain psychological disorders. The sociocultural approach emphasizes the social context in which a person lives, including gender, ethnicity, socioeconomic status, family relationships, and culture. For instance, poverty is related to rates of psychological disorders. If we look at a biopsychosocial model, so a combination of these, abnormal behavior can be influenced by biological factors such as genes, psychological factors such as childhood experiences, and social factors, cultural factors such as gender. These factors can operate alone, but they often act in combination with one another. Sometimes this approach is called the biopsychosocial. From the biopsychosocial perspective, none of the factors considered is necessarily viewed as more important than another. Rather, biological, psychological, and social factors are all significant ingredients in producing both normal and abnormal behavior. And an important concept that is helpful to psychologists to understand multiple influences in the development of psychological disorders is the vulnerability stress hypothesis model. These are several clinical disorders that we often see in patients. In order to diagnose, we use something called the DSM. We are currently on the DSM-5. In 1952, the American Psychiatric Association, APA, published the first major classification of psychological disorders in the United States, the Diagnostic and Statistical Manual of Mental Disorders. Its current version, DSM-5, was approved in 2013. This edition of the DSM is the product of a 14-year revision process. DSM-5 differs in many ways from its predecessors throughout the history of the DSM. The number of diagnosable disorders has increased dramatically. The DSM-5 includes new diagnoses such as binge eating disorder and gambling addiction. A general criticism that applies to all versions of the DSM is that it treats psychological disorders as if they are medical illnesses, taking an overly biological view of disorders that may have their roots in social experience. Even as research has shed light on the complex interaction of genetic, neurobiological, cognitive, social, and environmental factors and psychological disorders, the DSM-5 continues to reflect the medical model, neglecting factors such as poverty, unemployment, and trauma. Another criticism is that the DSM focuses strictly on problems, Critics argue that emphasizing strengths as well as weaknesses might help to destigmatize psychological disorders. It also relies too heavily on social norms and subjective judgments. There's too many new categories that have been added, some of which do not have consistent research support. Loosened standards for some existing diagnoses will add to the already very high rates of these. So there's been some changes as we go from one version to the next, and they are currently working on the next revision of the DSM-6, but is unknown as to when that will be released. So these are a few of the personality and developmental disorders. Disorders that usually occur in childhood. For example, if somebody is diagnosed with dissociative identity disorder, formerly known as multiple personality disorder, that usually stems from something traumatic that's happened in their childhood. There's a movie, The Three Faces of Eve, which documents the original case that was first diagnosed with, at the time it was multiple personality disorder, but it's an old black and white film. It does a pretty good job of portraying the different personalities in it, but that is one that I would recommend watching if you haven't seen that before. OCD is something else that you're probably familiar with. We hear about that very often. We'll talk about that a little bit later in the PowerPoint. Intellectual disability is formerly mental retardation, so we've updated the language for that terminology. And then paranoid disorder, panic disorder, those would be some other ones that would be part of this group. All right, so these are some of the different anxiety disorders that the DSM holds. Phobias, a fear becomes a phobia when a situation is so dreaded that an individual goes to almost any length to avoid it. Specific phobia is a psychological disorder in which an individual has an irrational, overwhelming, persistent fear of a particular object or situation. Fear plays an important role in adaptive behavior. It tells us when we are in danger and need to take action. The importance of this function suggests that fear should be relatively quickly learned, because learning to fear things will help harm us, keep us out of harm's way. Specific phobias might be considered an extreme and unfortunate variant on this adaptive process. Many explanations of specific phobias view these disorders as based on experiences, memories, and learned associations. Not all people who have a specific phobia can easily identify experiences that explain these, so other factors may also be at play. Each specific phobia may have its own neural correlates, and some people may be especially prone to develop phobias. The next one here, anxiety state disorder, or just anxiety in general. So we have generalized anxiety disorder, and then we have social anxiety disorder. Generalized anxiety disorder is a psychological disorder marked by persistent anxiety for at least 6 months, and by the individual being unable to specify the reasons for the anxiety. Among the biological factors are genetic predisposition, deficiency in the neurotransmitter GABA, and respiratory system abnormalities. The psychological and sociocultural factors include having harsh or even impossible self-standards, overly strict and critical parents, automatic negative thoughts when feeling stressed, and a history of uncontrollable traumas or stressors, such as an abusive parent. Treatment includes medications that mimic the action of GABA, as well as psychotherapy for anxiety. Social anxiety, or this can be called social phobia sometimes, is an intense fear of being humiliated or embarrassed in social situations. Genes appear to play a role, along with neural circuitry involving the thalamus, amygdala, and cerebral cortex. A number of neurotransmitters also may be involved, especially serotonin. And the DSM-5, generalized anxiety disorder, panic disorder, specific phobia, and social anxiety disorder are all classified as anxiety disorders. Treatment involves psychotherapy that aims at exposure to social stimuli while instilling a calm mindset. This may include in vivo and in vitro experiences. Medications to treat social anxiety include drugs that regulate serotonin and drugs that serve to reduce anxiety. Obsessive compulsive disorder. This disorder, also known as OCD, features anxiety-provoking thoughts that will not go away and/or urges to perform repetitive ritualistic behaviors to prevent or produce some future situations. Obsessions are recurrent thoughts and compulsions are the recurrent behaviors. There's one gentleman who suffers from this, and in the video he talks about how he fears that he killed somebody, and he feels that he put the body in the trunk, drove it to a field, and buried it. And the reason that this is OCD is because it's consuming his days. So he spends his entire day, he's not able to work, he's married, he's got kids, but he spends his day checking the trunk of his car, driving to this field where he thinks the body is buried, and walking this field for hours on end. He's been to the police. There's no evidence that any crime has ever been committed. There's no missing persons report. There's nothing that suggests that this is rational behavior or that it even ever happened. But in his mind, it is still real and he cannot break away from that. So this is very debilitating to his life. Sometimes this can go on for hundreds of times during a day for people that suffer from OCD. In terms of biological factors, there seems to be a genetic component. Brain imaging studies have suggested neurological links for OCD. One neuroscientific analysis is that the frontal cortex or basal ganglia are so active in the OCD that numerous impulses reach the thalamus, generating obsessive thoughts or compulsive actions. Low levels of the neurotransmitters serotonin and dopamine likely are involved in the brain pathways linked with OCD. According to the cognitive perspective, what differentiates individuals with OCD from those who do not have it is the ability to turn off negative intrusive thoughts by ignoring or effectively dismissing them. Treatments include behavioral approaches to counteract learned avoidance. Individuals are exposed to fear stimuli and instructed not to engage in rituals, which ultimately restructures learning since the dreaded outcome does not occur. This helps to extinguish the feared response. Other items that are related to OCD in the DSM-5 include hoarding disorder, body dysmorphic disorder, trichotillomania, which is hair pulling disorder, and excoriation, which is skin picking disorder. And post-traumatic stress, I know this is a little bit of a longer recording for you guys on this side, but post-traumatic stress is a disorder that develops through exposure to a traumatic event, a severely oppressive situation, cruel abuse, or a natural or unnatural disaster. Elements of anxiety are present. Symptoms of PTSD, they vary, but they could be consistent of flashbacks in which the individual relives the event, avoiding emotional experiences and avoiding talking about emotions with others, reduced ability to feel emotions, often reported as feeling numb, excessive arousal resulting in an exaggerated startle response or inability to sleep, difficulties with memory and concentration, impulsive behavior. PTSD symptoms can follow a trauma immediately or after months or even years. However, because not everyone who experiences the same traumatic life event develops PTSD, other factors aside from the event must influence a person's vulnerability to the disorder. These include a history of previous traumatic events and conditions, such as abuse and psychological disorders, cultural background, as in the case of traumatized refugees, and genetic predisposition. So what you're seeing here is a brain scan of identical twins. One has schizophrenia, one does not have schizophrenia. So you can see the difference in the brain scans between the two. Schizophrenia is a severe psychological disorder that is characterized by highly disordered thought processes. Schizophrenia is usually diagnosed in early adulthood around age 18 for men and 25 for women. Individuals with schizophrenia may see things that are not there, hear voices inside their heads, and live in a strange world of twisted logic. Psychosis refers to a state in which a person's perceptions and thoughts are fundamentally removed from reality. The DSM-5 recognizes a class of disorders called the schizophrenia spectrum and other psychotic disorders. And so schizophrenia and the different types would fall underneath this. There are positive and negative symptoms to schizophrenia. The positive symptoms of schizophrenia are marked by a distortion or an excess of normal function. They're positive because they reflect something added above and beyond normal behavior. Positive symptoms of schizophrenia include hallucinations, delusions, thought disorders, and disorders of movement. Hallucinations are sensory experiences that occur in the absence of real stimuli. Hallucinations are usually auditory. The person might complain of hearing voices or visual, and much less commonly they can be experienced as smells or taste. Delusions are false, unusual, and sometimes magical beliefs that are not part of the individual's culture. Thought disorder refers to the unusual, sometimes bizarre thought process that's characterized positive symptoms of schizophrenia. The thoughts of persons with schizophrenia can be disorganized and confused. Often individuals with schizophrenia do not make sense when they talk or write. A person with schizophrenia can show referential thinking, which means giving personal meaning to completely random facts. The final type of positive symptoms is disorders of movement. A person with schizophrenia may show unusual mannerisms, body movements, and facial expressions. The individual may repeat certain motions over and over, or in extreme cases may become catatonic. Catatonia is a state of immobility and unresponsiveness that lasts for long periods of time. Negative symptoms, where schizophrenia's positive symptoms are characterized by a distortion or an excess of normal functions. Negative symptoms reflect social withdrawal, behavioral deficits, and the loss or decrease of normal function. One negative symptom is flat affect, which means the display of little or no emotion. Individuals with schizophrenia also may be lacking in the ability to read the emotions of others. Cognitive symptoms of schizophrenia include difficulty sustaining attention, problems holding information in memory, and inability to interpret information and make decisions. There are biological, psychological, and social factors that can cause schizophrenia. There's a hereditary component. There are structural brain abnormalities, problems in neurotransmitter regulation. That's all part of your biological factors. Psychological factors can be stress, which can contribute to the development of schizophrenia under certain conditions. The vulnerability stress hypothesis suggests that individuals may have biological risk factors that interact with experiences to produce the disorder. And then sociocultural is not a cause of schizophrenia, but sociocultural factors do affect the course of the disorder or how it progresses. Individuals with schizophrenia in developing non-industrialized nations are more likely to show indications of recovery over time compared to those in developed industrialized nations. In developing nations, families remained involved in individuals' lives after diagnosis, and many families lived in close-knit communities where care of their loved one was not so burdensome. In developed nations, schizophrenia is strongly associated with poverty, but it is not clear if poverty increases the likelihood of experiencing the disorder. Marriage, warm and supportive friends, and employment are related to better outcomes for people diagnosed with schizophrenia. So depression, mania, bipolar, and seasonal affective disorder. Well, we don't really call it manic depressive disorder anymore. We combined that into bipolar. So bipolar has your mania or manic episodes, and then it has your depression as the opposite to that. Seasonal affective disorder is your moods based on the season. So oftentimes we see people with SAD that are more depressed in the wintertime, and that can be due to lack of sunlight, just changes in routine, the cold weather sometimes. So there can be different contributing factors to seasonal affective disorder. Major depressive disorder is the one that we probably see the most. It involves a significant depressive episode and depressed characteristics such as lethargy and hopelessness for at least 2 weeks. And when I say that we see this the most, I do crisis work, and so major depressive disorder is one that we commonly diagnose with when we see people that are in crisis and needing hospitalization. The symptoms of major depressive disorder can include being depressed, in a depressed mood most of the day, reduced interest or pleasure in activities that were once enjoyable, significant weight loss or gain, significant decrease or increase in appetite, trouble sleeping or sleeping too much, fatigue or loss of energy, feeling worthless or guilty in an excessive or inappropriate manner, problems in thinking, concentrating, or making decisions, recurrent thoughts of death and suicide, and no history of manic episodes or periods of euphoric mood. Individuals who experience less extreme depressive mood for more than 2 months may be diagnosed with persistent depressive disorder. This disorder includes symptoms such as hopelessness, lack of energy, poor concentration, and sleep problems. And then there's also the 3 different factors, again, biological, psychological, and sociocultural, that can play a role in this. Bipolar disorder is a disorder characterized by extreme mood swings that include 1 or more episodes of mania, an overexcited or unrealistic optimistic state. The person who experiences mania feels on top of the world. A manic state also features an impulsivity that can get the individual in trouble. Most bipolar individuals experience multiple cycles of depression interspersed with mania, usually separated by 6 months to a year. Unlike depressive disorders, which are more likely to occur in women, bipolar disorder is equally common in women and men. Genetic influences are stronger predictors of bipolar disorder than of depressive disorders. Metabolic activity decreases in the brain during depression and increases during mania. In addition to the high levels of norepinephrine, the low levels of serotonin, studies link high levels of the neurotransmitter glutamate to bipolar disorder. Okay, so suicide. Approximately 90% of individuals who commit suicide are estimated to have a diagnosable mental disorder. The most common disorders among individuals who commit suicide are depression and anxiety. Genetic factors appear to play a role in suicide, which tends to run in families. Studies have linked suicide with low levels of the neurotransmitter serotonin. Poor physical health, especially when it's chronic, is another risk factor for suicide. We see an increase in our children and adolescents that are attempting and completing suicide. We also see an increase in our elderly population with same thing, either attempting or completing suicide. Psychological factors can contribute to suicide. This can be a psychological disorder, a traumatic experience, an immediate and highly stressful circumstance, such as the loss of a loved one or a job, flunking out of school, an unwanted pregnancy. These are all things that can lead people to threaten and or to commit suicide. Social cultural factors, chronic economic hardship can be a factor in suicide. Cultural and ethnic contexts are also related to suicide attempts. Women are 3 times more likely than men to attempt suicide. Men, however, are 4 times more likely than women to complete suicide. And that's due to the different methods in which they attempt suicide.